See, the chest X-ray can be of the following views. It can be a posterior-anterior view, antero-posterior view, lateral view, oblique or decubitus view. Now, what are the precautions that to be taken while X-rays is when a physiotherapist visits X-ray department to observe the procedure, he or she must stand behind the X-ray tube whenever possible. We should not get exposed to the X-rays. Be as far away as possible away from the X-ray tube. Wear a lead rubber apron when necessary. Now the first view is posterior anterior view. See, actually for every radiograph procedure, there will be an emitter through which X-rays are emitted, and there will be a cassette where your X-rays are recorded. So in posterior anterior view, this is how the patient will be exposed. Now this is, and the view will be like this. Basically, why we want to take a posterior anterior view instead of AP view is to avoid the shadows of scapulae. In lateral view, this is the how the cassette is placed to the lateral side of the patient, and this is the decubitus view. So this is the emitter and this is the cassette. Suppose if the cassette is on the anterior side of your body, it is PA view, yani posterior anterior view. If the cassette is on the anterior side of the body, posterior side of the body, it is AP view. Okay, so wherever the cassette is being placed, the X-ray view will be changed. Now coming to the radiograph reading, see, when reading a chest radiograph, it is important to follow some routine orders. Okay, so you cannot simply read, you have to go for, to avoid what do you call any changes, to avoid the skip of any changes, you have to go in a relevant way. Chest X-ray is one of the most frequently requested hospital investigations. It is readily available and inexpensive in comparison to other imaging studies. Between 100 and 150, you get a chest X-ray, whereas your scan will come around 3,000 to 4,000. So it is very inexpensive when compared to other investigations. That's why it is off, and it is very fast. Immediately you can get a film. The basic interpretation is of utmost importance in answering several clinical questions at hand. It is an important tool to complement both history and initial clinical examination. Basic chest X-ray interpretation. See, when you take a chest X-ray, on the top, you will have the name of the patient, age, and date on which the X-ray has been taken. Then you have to check the quality. Image quality influences interpretation. Quality is influenced by radiographic technique and patient factors. First, determine if the clinical question can be answered. Check the image for projection, rotation, inspiration, penetration, and artifacts. Projection. Look to see if the film is antero-posterior or posterior anterior view. With an AP view, the X-ray beam is in front, the patient, and the X-ray placed at the back, that is the cassette, and the other way around for PA view. The standard chest X-ray is PA, but many emergency chest X-rays are antero-posterior. The chest X-ray projection has an important bearing on the interpretation of the structures. Now posterior projection, see here, this is the cassette, this is the patient, and this is the X-ray source. So from behind the X-ray source is X-rays are uh, placed over the patient, and the image is captured from the front side. So this is called posterior anterior projection. The standard chest radiograph is acquired when the patient is standing up and with the X-ray beam passing through the patient from posterior to the anterior. The chest X-ray image produced is viewed as if looking the patient from the front, face to face. The heart is on the right side of the image as you look at it. What are the key points here to note is posterior anterior is the standard projection. PA projection is not always possible. Both PA and VP views are viewed as if looking at the patient from the front. PA views are of high quality and more accurate. Assess heart size than AP images. If an AP projection is performed, ask yourself if the clinical question can still be answered. Now, PA projection, X-rays pass from the posterior to the anterior of the patient, hence posterior anterior projection. The image is viewed as if you are looking the patient face to face. Now, anterior-posterior projection or AP projection, sometimes it is not possible for radiographers to acquire a posterior-anterior chest X-ray. This is usually because the patient is too unwell to stand. The chest X-ray image is still viewed as if looking the patient face to face. X-rays pass from anterior to the posterior of the patient, hence anteroposterior projection. The image is still viewed as if you are looking the patient from face to face, but you will get the shadows of scapula. AP versus PA view, heart size. The heart being an anterior structure within the chest is magnified by an AP view. Magnification is exaggerated further by the shorter distance between the X-ray source and the patient, often required when acquiring an AP image. This leads to a more divergent beam to cover the same anatomical field. As a rule of thumb, you should never consider the heart size to be enlarged if the projection is used is AP. If, however, the heart size is normal on the AP view, then you can say it is not enlarged. Next is orientation. Identify the left and right markings. So there will be definitely R and or L will be written on the top of the X-ray to identify which side is right and which side is left. Identify the anatomical structures, erect or supine. Do not always assume that the heart will always be on the left because certain pathologies can result with mediastinal shift. Dextrocardia, that is heart being on the right side, can also be a possibility. You do not have to solely rely on just chest X-ray markings. Clinical examination is also very important. Then coming to the rotation, identify the medial ends of the clavicles and select one of the thoracic vertebra spinous process that falls between them. The median ends of the clavicle should be equidistant from the spinous process. If not, in that case, the X-ray is rotated. That means the patient has rotated during the taking the X-ray. See, you choose a thoracic spine. You measure the distance from here to the medial end of the clavicle, here on one side and on the other side. Both should be equal. If not, the chest X-ray is being rotated. Find the medial ends of the clavicle, find the vertebral spinous process. The spinous process should lie halfway between the medial ends of the clavicles. Inspiration, degree of inspiration. See, whenever you go to an X-ray for a AP view or PA view or lateral view, the radiographer will ask you to take a deep breath and hold. So, inspiration, how much good degree of inspiration has been done. To judge the degree of inspiration, count the number of ribs above the diaphragm. Above the diaphragm, you count the ribs. The midpoint of the right hemidiaphragm should be between the fifth and seventh ribs anteriorly. The anterior end of the sixth rib should be above the diaphragm, as should the posterior end of the 10th rib. If more ribs are visible, the patient is hyperinflated. If fewer, it indicates inadequate inspiration. Poor inspiration will make the heart look larger, give appearance of basal shadowing, and cause the trachea to appear deviated to the right. See, you check rib is which rib is intersecting the diaphragm. Usually the seventh rib should be intersecting the diaphragm and it should be mid-clavicular. Then it is normal, normal inspiration, good inspiration. The ribs play a role in assessing the adequacy of inspiration taken by the patient. The anterior end is approximately 5 to 7 ribs. Fifth rib or seventh rib should be visible above the diaphragm. You should be able to see from fifth rib to seventh rib above the diaphragm easily. Visible above the diaphragm in the mid-clavicular line. Less than this indicates an incomplete breathing, and more than 7 ribs of flattening of diaphragm suggests lung hyperexpansion. On the normal X-ray, the anterior end of the seventh rib intersects the diaphragm at the mid-clavicular line. The chest X-ray also demonstrates the subcostal grooves of the underside of the ribs. See here, the red color, what you are observing are subcostal grooves. You should be able to see this. In real X-ray, it will not be red in color, but you will be able to see as a groove. We have just highlighted to make it visible. The chest X-ray also demonstrates the subcostal grooves on the underside of the ribs. These grooves contain the neurovascular bundle anteriorly. The sixth rib intersects the diaphragm at the midclavicular line. The lungs are not consolidated. The heart size is clearly normal. You see here no consolidation. Clear image. Next, penetration. To check the penetration, look at the lower part of the cardiac shadow. The vertebral bodies should be barely visible through the cardiac shadow at this point. If they are clearly visible, then the film is over penetrated. If they are clearly visible, the vertebral bodies. The vertebral bodies are clearly visible, then the film is over penetrated and you may miss low density lesions. If you cannot see them at all, then the film is under penetrated and the lung fields will appear falsely opaque white. The left hemidiaphragm should be visible to the edge of the spine. When comparing X-rays, first determine if the level of penetration is similar. So both side penetration is similar or not, you have to see. This is under penetration. The left hemidiaphragm is not visible. See, right hemidiaphragm is visible, left side is not visible. This is under penetration. If you get an X-ray like this, it is under penetration. Right side hemidiaphragm you can see, left side you can see, and the right side you are unable to see. Lung tissue behind the heart cannot be seen. Re-windowing the image using digital software can compensate. Under penetration, the left hemidiaphragm is not visible to the spine. See, the spine is not clearly seen. Lung tissue behind the heart cannot be assessed. Re-windowing the image using digital software will compensate. What is re-windowing? Over image, it is called as. The diaphragm is visible to the spine. The left paraventricular soft tissues are visible. There is no abnormality of the lung tissue behind the heart. Chest X-ray anatomy. A normal chest X-ray. This is trachea. What you are observing here, number 1. Number 2, hilum of lungs. Hilum of the lungs. Number 3, lungs. Number 4, diaphragm. Number 5, heart shadow or cardiac shadow. Number 6, aortic knuckle. Number 7, ribs. Number 8, scapulae. Number 9, breast. Number 10, stomach. And this is a gas bubble. Important thing is sternum you cannot see, esophagus, spine, pleura, fissures and aorta. Trachea, it should be central or slightly deviated to the right. When you observe the trachea, it should be central or slightly towards the right. See, this is left side, so it should be slightly towards the right side. In case of deviation, decide if it is due to rotation or pathology. As I told you, to check whether the trachea is central or not, check the distance from a spinous process to medial clavicle, middle surface of the clavicle. It should be equidistant, and still you find there is some deviation, some difference from the spinous process, then there is deviation of trachea. View the carina. Angle should be between 60 to 100 degrees. Because it contains air, it appears darker, blacker and radiolucent. Trachea normally narrows at the vocal cords T3 to T4. HLAR structures, also called lung root, consists of major bronchi and pulmonary vessels, veins and arteries. The HLAR are not symmetrical but consists of same basic structures. The lymph nodes are also present but not visible unless abnormal. The HLAR point, by convention, the HLAR points are the angle formed by the descending upper lobe veins as they cross behind the lower lobe arteries. Not every normal patient has a very clear HLAR point on both sides. This patient has. But if they are present, they can be useful in determining the positioning of the HLAR. Next, lungs. The lungs occupies the largest portion of the thoracic cavity. The lungs are assessed and described by dividing them into upper, middle and lower zones. The lung zones do zones do not equate to lung lobes. Example, the lower zone of the right lung consists of middle and lower lobes. Compare left with right. Compare an area of abnormality with the rest of the lung on the same side. If there is any asymmetry, decide which side is abnormal. Then pleura and pleural spaces. The pleura are only visible when there is an abnormality present. This can be due to pleural thickening and fluid or air accumulating in the pleural spaces. Lung markings should reach the thoracic wall. Normal invisible pleura. Your lung should that black color one should be in touch with the thoracic cavity. Trace round the entire edge of the lung where the pleural abnormalities are more readily seen. Start at end of the HLAR. Is there any pleural thickening? Is there any pneumothorax or is there any effusion? Costophrenic angle and recess. The costophrenic recesses are formed by hemidiaphragms and chest wall. They contain the rim of the lung bases which lie over the dome of each hemidiaphragm. These angles are known as costophrenic angles. Costophrenic angles should form acute angles that are sharp to the point. On a PA view, the costophrenic recesses are seen on each side as the costophrenic angles. The costophrenic angle consists of the lateral chest wall and dome of each hemidiaphragm. These are costophrenic angles. Hemidiaphragm. Here you can see the right hemidiaphragm lying slightly higher than the left. This is left side. This is right side. The liver is located immediately inferior on the diaphragm of the right. The stomach bubble can be seen below the left hemidiaphragm and through the ribs. Normal lung is seen. If you look closely, you can see lung markings below the diaphragm on both sides. This. Medial. Hello. Good evening.
Sir?
हाँ बताओ मैं क्लास में हूँ 10-15 मिनट लगेगा ऑनलाइन क्लास में हूँ Medially, the hemidiaphragm forms an angle with the heart. These are called as cardiophrenic angles. The left and right hemidiaphragms are almost superimposed on a lateral view. Anteriorly, the left hemidiaphragm blends with the heart and becomes indistinct. Next, heart. The heart lies more to the left of the thoracic cavity. The heart is assessed by means of cardiothoracic ratio, which commonly called as CTR. That is cardiac width to the thoracic width. Cardiothoracic ratio more than 50% is abnormal in PA view. The left hemidiaphragm should be visible behind the heart. The hemidiaphragms do not represent the lowest points of the lungs. Cardiac size is measured by dropping parallel lines down both sides of the heart. First draw a parallel lines onto the both lines at the most lateral points on each side and measure them to measure the both points. Thoracic width is measured by dropping parallel lines onto the widest points of the rib cage and then measuring. So the cardiac thoracic ratio can be stated. Here it is 15:33 and is therefore within the normal limits, that is 50%. cardiac contours. The left heart contour consists of the left lateral border of the left ventricle. The right heart contour is the right lateral border of the right atrium. Next, the mediastinum. The mediastinum contains the heart and great vessels and potential spaces in front of the heart, behind the heart, and above the heart. These potential spaces are not defined on a normal chest X-ray, but their awareness can help in describing location of the disease process. There are several structures in the superior mediastinum that should always be checked. They include aortic knuckle, aortopulmonary window, and the right paratracheal stripe. This is the aortic knuckle. Aortic pulmonary window.
Hello, sir, you are not audible. Hello? Sir, you are not